to introduce today's speakers, Dr. Tony Garcia-Prats, Ms. Anne Raftery, and Ms. Kayleen Jacobs. Tony Garcia-Prats is currently based at the Desmond Tutu TB Center at Stellenbosch University in Tygerberg, South Africa, doing clinical care and research in children with drug-resistant tuberculosis, with a focus on the pharmacokinetics and toxicity of anti-tuberculosis drugs in children. And Raftery is a tuberculosis nurse trainer and regional consultant with the Curry International Tuberculosis Center at the University of California, San Francisco. She has been contributing to TB control program and human resource development in various capacities over the past 28 years in North America, the Caribbean, and Africa. Kayleen Jacobs is currently working at Brooklyn Chest Tuberculosis Hospital as an audiologist and has been there for 5 years in the TB program. Ms. Jacobs is also a clinical educator to audiology undergraduate students from the University of Cape Town. And I will turn you now over to Dr. Garcia-Prats. Thank you.
Outcomes. We're going to discuss some brief rationale and background, and then really follow through how you would approach the questions about managing injectable drugs for a child who's in front of you. So what would be the indications for giving an injectable? How would you choose a drug? What the dose would be and the duration of treatment? And then how to actually administer it safely, how to monitor it, and then a little bit about the future of injectable management in children. So at the end of the session, we'd like you to be able to prescribe an appropriate dose of the injectable TB medications to a child. 2, be able to choose the appropriate site and needle size for safe administration of an IM injection of an injectable TB drug to children of different ages and sizes. And then lastly, to be able to choose the most appropriate audiologic monitoring strategy for children of different ages. Why did we think it was worth your time and our time to discuss managing injectables in children? I think there's a number of different reasons. These are really the least well tolerated of the second-line medications. They cause a lot of pain with the injections, and they have a lot of serious permanent adverse effects. So managing them appropriately and safely is important. As I just mentioned, hearing loss is a major concern for obviously for children and parents, but also for healthcare providers who are deciding about whether to treat children with injectables and how to do that best. There are specific issues to children around injectables, including dose and duration, how to administer safely, and monitoring for ototoxicity that are a little bit different compared to adults. And then lastly, this is really important, is that the discomfort about managing injectables and concerns about giving IM injections, how to best do that, the risks of adverse effects may actually limit access to children who would otherwise benefit from MDR TB treatment. So we feel like it's an important topic to discuss. So a little background about the injectables. These are WHO Group 2 medications. The aminoglycosides include amikacin, kanamycin. Streptomycin is an aminoglycoside that's used for TB treatment, but really doesn't have much of a role in the management of MDR TB, so we're not going to discuss that today. And then capreomycin is a cyclic polypeptide, so a similar drug group and is in group 2. All of these medications inhibit mycobacterial protein synthesis. That's their mechanism of action. And they're all the same in that they must be given IV or intramuscularly, as they're degraded immediately if they're given orally. What is actually the evidence, and why are these important medications for the treatment of MDR TB? They have potent, all of them have potent activity in vitro and animals. So if you put these medications in a test tube or into animals with TB, they actually kill TB quite effectively. But in humans, they have minimal early bactericidal activity, and that's how we measure how well a medication works to kill actively metabolizing, dividing TB bugs. And the reason why this is so different than the in vitro and animal data is not entirely known, but the authors of the EBA study suggested it may be related to poor penetration of these drugs into cavities, which is obviously an important consideration. And also these medications are inactivated in an acidic environment, which it is in cavities. The evidence really suggests minimal sterilizing activity of these medications as well. So they're not good at killing persisting TB germs, which is important for preventing relapse. So what is actually the evidence? Why are we giving these? Maybe the best evidence is from MDR patients who have additional resistance. And the odds of treatment success for a person who has MDR with additional second-line injectable resistance is 0.6 compared to those whose MDR is susceptible to Ofx and a second-line injectable. So really, if you're resistant to your injectable, you have a lower odds of treatment success, and really suggests that those medications have an important role in MDR TB treatment. Although really the evidence is low quality, and there are no randomized controlled trials demonstrating that the exact role of these drugs in MDR treatment in adults or children. So moving on to a little bit more of a pragmatic focus. So when should you decide to give an injectable? How would you decide which drug to give, and what dose would you choose, and how long would you give it? So really the indication for a second-line injectable is MDR TB in children, and that could be confirmed MDR, probable MDR, or possible MDR. And just as a reminder, confirmed MDR is in a child who has signs and symptoms that are consistent with TB, and you actually detect MTB that's resistant to INH and RIF. Probable MDR would be the diagnosis of probable TB disease, so that would be signs and symptoms and a consistent radiograph and DR-TB contact. And possible MDR would be diagnosis of probable TB disease with either contact of a source case who has risk factors for DR-TB or failure of adherent first-line TB treatment. All of these should probably be an indication to give a second-line injectable medication. And really, these are key components of the current regimens in both adults and children. If a child has XDR-TB, that may also be an indication for a second-line injectable. It's important to keep in mind that there is substantial cross-resistance, and the choice or whether to use an injectable really depends on previous treatment and on the current drug susceptibility test results. So which injectables should you give? There's a number of considerations. Certainly potency, or how strong the medication is, might be an important consideration. There are no head-to-head studies in humans comparing the efficacy and safety of the injectables. And really the expert opinion is that these drugs can be used interchangeably. Cost may be a consideration. So capryomycin is more expensive, substantially more expensive than amikacin or kanamycin. But in reality, if you're in the field, then really the main consideration is what you have access to, and that's what you should use. And for children with MDR TB, that tends to be amikacin or kanamycin, and that's fine. Most programs, partly because of the cost, will reserve capryomycin for patients who have XDR TB. But it is important to consider that there is a substantial amount of cross-resistance. So patients with XDR TB, by definition, have resistance to an injectable agent, a second-line injectable agent. And at least in 2 recent studies published from South Africa, patients with XDR already had 87% and 90% in 2 cohorts were resistant to capryomycin already. And that may vary from setting to setting, but it's certainly something to keep in mind. So once you've decided an injectable is indicated and you've decided on the medication you're going to give, it's important then to decide what dose you're going to give to the child in front of you. All of these amikacin, kanamycin, and capryomycin essentially have the same pharmacokinetics. So they must be given by intramuscular or intravenous injection, and IV and IM have essentially the same PK. These medications are well absorbed after IM injection. If they're given IV, they're usually infused over 30 to 60 minutes. It's important to note that they have poor penetration into CSF and cavities. In children, it's particularly important that penetration into CSF, as a substantial portion of children with MDR TB will also have TB meningitis. These medications are eliminated primarily unchanged by the kidney. There's actually limited PK data in children with TB There is a good amount of PK data on amikacin in children, but again, not much in children with TB, and very little PK data on kanamycin and capreomycin in children. So these medications have concentration-dependent activity, so their activity is going to be dependent on how high you can get the dose and how high you can get concentrations in the blood and their area under the curve. These are the key pharmacodynamic measures. Now the proposed target Cmax is 35 to 45, but that should be interpreted with caution, and that's really based on fairly low quality evidence, but at least it's something with which to judge the pharmacokinetics. And just to give you an idea of some preliminary results from a study of the PK and safety of second-line TB drugs in children that we're performing here in Cape Town, with an amikacin dose of 20 milligrams per kg, you can see that the Cmax in all of the different age groups, the median Cmax was 43, 49, or 49. So the majority of the children receiving a 20 milligram per kg dose of amikacin in our population had a Cmax that was above the proposed adult targets. So that was obviously concerning, and you can see in this table the WHO recommendations for dose 15 to 22.5 milligrams per kg once daily for amikacin, or 15 to 30 once daily for kanamycin. Based on our data, and our current practice here is actually to keep that to the much lower end of the spectrum for once daily dosing, and we target a range of 15 to 20 milligrams per kg. How long should you give the injectables? So the WHO recommendations for adults that were updated in 2011 suggest an 8-month intensive phase, which would include an injectable. But they're not specific recommendations for children. In our experience, children rarely require more than 6 months of treatment, and we've rarely given 8 months of an injectable to children. Certainly that can be individualized if a patient is having poor response or depending on the other drugs that you have that are available to you and likely to be active. But really rarely should children require more than 6 months. And it may actually be possible to have good outcomes with shorter durations of injectables, and there's been some nice publications showing just that. It may depend on a lot of other factors, whether there's fluoroquinolone susceptibility. It's more likely to do well. Children are more likely to do well with shorter durations of injectables if there's non-severe disease. And if they're having a good response to treatment, that would obviously be important. So that is an option and something to very carefully consider, whether a shorter duration may be relevant to children in your care, and you may want to do that in consultation with a clinician who's highly experienced in MDR TB in children. Okay, so we've discussed when an injectable is indicated, how to choose a drug, how to dose that appropriately, and how to consider how long you're going to give that. But then you actually have to administer these medications to children, which really introduces a lot of practical questions and challenges. And so I'm going to hand over to Anne Raftery to discuss safe administration and injection.
Thank you, Tony. So just to highlight what I'll cover in the next few slides, I'll provide background as to why this is an important topic to address, review current practice guidelines for IM injections in children, most pertain to immunization, point out where the existing guidelines may not suit the situation of treatment for MDR TB, then conclude with proposed recommendations. I hope this will generate interest in developing practical practice guidelines for IM injection in children receiving an injectable for MDR TB. I want to just note that in the interest of time, I will not be covering comfort measures for general procedure, positioning of the patient, although I recognize these are also important considerations for successful injections. It's worth noting that there is limited evidence to guide best practice recommendations for IM injection in infants and children. The current guidance is largely based on vaccination-related studies and on case reports of adverse events following IM injections, which has led to recommendations for practice change. Case reports of IM injection-related injuries to infants and children other than following vaccinations involve injection of antimalarials, antibiotics, vitamin K, and other medications. Many of these reports implicate poor injection site selection or poor injection practice. Some authors suggest that as these injuries are fairly common, physicians feel it unnecessary to publish about it, and therefore these types of injuries are likely to be underreported. So as you know, and as Tony mentioned, the standard treatment regimen for MDR TB includes a daily injectable for about 6 to 8 months. This equates to a little over 200 IM injections during the intensive phase of treatment if 8 months is given. In the industrialized world, the injectable can be given intravenously, and this is the preferred route. However, in settings where human resources are scarce and where drug-resistant TB is thriving, pediatric MDR TB patients, if they're diagnosed and started on treatment, commonly receive the injectable intramuscularly. And currently, there is no guidance on best practice for daily IM injection of aminoglycosides or capreomycin for infants and children receiving treatment for MDR TB. So let's look at what we have in terms of guidelines. Existing guidelines for IM injection of immunizations and other injectables are largely founded on expert opinion, and there continues to be some variation across expert authorities. This table summarizes recommendations of the IM injection site and needle size for different pediatric age groups from 3 different health authorities: the World Health Organization, Centers for Disease Control and Prevention in the US, and Public Health England, Department of Health, Social Services and Public Safety in the UK. The one area of consensus is in infants less than 1 month, where all 3 authorities recommend use of the vastus lateralis for IM injections. This site is also referred to as the anterior lateral thigh. So why not just apply the recommendations being used for vaccination to the administration of the injectable agent for the treatment of MDR TB? What's different? First, a daily injection is required. Secondly, the number of IM injections is greater, over 200 in the span of 8 months. I've yet to hear of another medical condition that requires even close to this number of daily IM injections. And lastly, the volume of aminoglycoside to be injected exceeds a typical vaccination volume by the time a child is 10 kilograms. So getting back to the basics, there are several factors to consider when selecting a site for IM injection. These include the volume, consistency, and chemical property of the medication, the size and development of the muscle, the presence of underlying nerves or major blood vessels, and lastly, whether repeated injections are necessary. When repeated injections are needed, the injection site should be rotated, and therefore we are going to need multiple IM sites for the pediatric MDR TB patient. With this in mind, let's look at what we know about maximum volume by injection site. So to date, I've been unable to find data that specifically examines this question for infants and children. However, experts suggest that it depends on the physiochemical property of the medication to be injected and the muscle size. Now, this is an important question to answer to guide decisions on the appropriate IM injection site for pediatric MDR TB patients. As using the latest World Health Organization dosing guidelines of 15 to 30 milligrams per kilogram for the aminoglycoside, the volume of the aminoglycoside a child less than 30 kilograms would receive would be somewhere between 2 to 3.5 mils. A child in the range of 14 kilograms would likely be receiving about 1 mil or more. Expert opinions have suggested a maximum volume ranging from 1/2 to 2 mils, depending on the child's age, muscle site, and its development. Of the potential IM injection sites, there really are only 4 that are consistently mentioned in the literature for infants and children, and for the 2 gluteal muscle sites, there's still much controversy. So let's review now each one of the 4 IM injection sites. The vastus lateralis is one of the quadriceps femoris muscles. It's located along the anterior lateral aspect of the thigh between the greater trochanter of the femur and the lateral femoral condyle. The target IM injection area is the middle third of the muscle, lateral to the midline of the anterior thigh, and the injection area is highlighted here in red. The advantages of this site is that it's easy to locate and accessible. It has a relatively large muscle mass that's well developed at birth, and therefore it can be used in a young infant. It also provides a fairly large surface area, which is needed when multiple injections are required. And it's away from the femoral nerves and blood vessels. The disadvantages are that it's not entirely free from complications. The most frequently reported complication is fibrosis and contractures of the quadricep muscle, most following multiple injections during infancy. The dorsogluteal muscle is located on the upper outer quadrant of the buttock. The important landmarks for safe injection into this muscle are the posterior superior iliac spine and the greater trochanter. These landmarks should be identified by palpation with an imaginary line drawn diagonally between them, and the target injection area is midway above this line as noted in the graphic. Reported advantages include its relatively large muscle mass that's well developed after the child has been walking for about a year or more. Additionally, it can accommodate multiple injections given its larger surface area compared to the ventrogluteal and deltoid sites. Important disadvantages, however, are that in infants, the gluteal area is extremely small with very small muscle mass. This area is composed primarily of fat. The infant starts to walk and the muscle begins to develop. There's also the potential for sciatic nerve injury and other complications such as sterile abscess and necrosis, particularly in infants and children without sufficient muscle mass or when an injection is improperly placed. The ventrogluteal consists of the gluteus medius and minimus muscles, and the area for injection is located at the hip in an inverted triangle as shown on the slide. Landmarks for locating are the iliac crest, the anterior superior iliac spine, and the greater trochanter of the femur. Some advantages of this site are that the bony landmarks are easy to palpate, making the site simple to localize. It also has a greater thickness of gluteal muscle than the dorsogluteal, along with a thinner layer of subcutaneous fat, making intramuscular placement of an injection easier to achieve. And it's free of large penetrating nerves and blood vessels, therefore there's less potential for significant nerve or vascular injury. Important disadvantages are that nurses may not have been trained to locate and use this site, therefore they may be reluctant to consider it. And secondly, the area of injection is quite small, limiting its use when repeated injections are required, such as for MDR TB. And lastly, the deltoid. The deltoid is located laterally on the upper arm. Landmarks for locating are the acromion process and the deltoid tuberosity as shown here in the figure. The injection site is at a point halfway from the acromion process to the deltoid tuberosity. Some suggest drawing an imaginary inverted triangle whose apex is above the level of the armpit, as shown in this triangle. Reported advantages are that the site is easily accessible, medication is well absorbed from this site, and reported complications have been few. Important disadvantages are that because of its small size, it's not recommended for repeated injections or for volumes greater than 1 ml. Contractures of the deltoid muscle secondary to injections have been reported, and nerve injury is a potential complication if the injection is given improperly. So what about injection angle and needle size? Well, the needle size should be long enough to reach into the muscle, but not so long as to reach underlying nerves, blood vessels, or bone. Although needle length guidance may be provided, clinical judgment should always be used in selecting the appropriate size based on assessment of the target muscle. And this is particularly important with regards to the pediatric MDR TB patient who may present with evidence of muscle wasting and malnutrition. In terms of the injection angle, there now seems to be consensus that the IM injection should be given at a 90-degree angle to the skin. The rationale being that it maximizes the depth of penetration into the muscle, making it less likely the injection will inadvertently be placed into the subcutaneous layer where absorption would be poorer and complications could result. Even slightly less perfect injections will likely give good placement into the muscle if the nurse is aiming for a 90-degree insertion, if the right needle size has been selected, and if the insertion is up to the hub. So given what we've reviewed, the following table outlines proposed recommendations to stimulate discussion towards the development of guidelines for safe daily IM injection of the treatment of the pediatric MDR TB patient when intravenous administration is not feasible. I've highlighted in red where the proposed recommendations vary from the previously reviewed existing guidelines. It's worth noting that the World Health Organization recommends IM injections in the thigh, not in the buttock, in children less than 5 years of age. Presumably this refers to avoiding the dorsogluteal muscle. Therefore, in children less than 5, the preferred site would be the vastus lateralis, or the anterior lateral thigh. This site can be rotated left and right within the middle third injection range that we discussed earlier. When an alternate site is needed, the ventrogluteal site could be used. The deltoid could be a secondary IM site for younger children when the volume of medication is less than or equal to 1 ml. However, the WHO does not consider the deltoid a safe IM injection site for children under 15 months of age, stating the muscle is insufficiently developed to absorb medication adequately and due to the superficiality of the radial nerve. Therefore, whether the deltoid should be included as an alternate site for this 1 to 3-year-old age group should be debated. Last point I wanted to make is that the American Academy of Pediatrics recommends the vastus lateralis as the preferred site for all age groups and reserves the use of the ventrogluteal and dorsogluteal sites for children over the age of 3, noting that the dorsogluteal should be considered when the volume of medication is large because of its muscle mass and surface area is greater. So in conclusion, complications from IM injection can occur even when appropriate precautions are taken. Currently, we lack guidance to influence IM injection practice for delivery of the injectable agent in the treatment of pediatric MDR TB, and official recommendations are needed to guide safe practice. Until such guidelines are available, avoiding IM injection-related injuries will require that nurses know the advantages and disadvantages of the possible injection sites, taking into consideration the age of the patient as well as the weight and nutritional status. They must know the anatomy, being able to accurately assess muscle mass, anatomic landmarks, as well as cite the boundaries for IM injection, and they must know particulars about the injection technique, including injection angle and site rotation, as well as other aspects that we didn't cover today, including injection speed, use of aspiration or Z-track methods. So with that, I just wanted to thank you, and I'll hand it back to you, Tony.
Of these medications, if you've witnessed IM injections or children receiving these, you don't have to be told how painful they are, or if you've received them yourself. One consideration for limiting the pain is to add lignocaine or lidocaine to IM injections. This has actually been studied for other IM injections, including penicillin and ceftriaxone. And in those instances, it's been shown to be safe and to reduce the pain substantially and not influence the pharmacokinetics, the absorption of the medications. This hasn't been well studied for the injectable TB drugs. In practice here in Cape Town, we are adding lignocaine to injections of these medications, giving a very small volume, 0.2 to 0.5 mils of lignocaine added to the injectable agent, depending on the volume of the medication and the size of the child. A key consideration is to avoid injecting directly into a vein, which could cause adverse effects. But this can be safely avoided with careful injection administration. Studies are actually underway to evaluate both the safety of this approach, the PK, and also the influence on pain. But this is our routine practice, and I think it is something to consider given how painful these injections actually are. The most common adverse effects, or adverse effects really to be aware of, are nephrotoxicity. And this appears to be more common in adults who are receiving these medications. It's actually been rare in our experience in children with the doses that we've previously discussed. Electrolyte abnormalities are also possible. Hypokalemia, the most frequent, but also hypomagnesemia. These appear to be more commonly associated with capreomycin, particularly in adults. And again, in our experience, we've very rarely seen any abnormalities in potassium or magnesium, and certainly very rarely any abnormalities that are clinically relevant. We do monitor creatinine and potassium regularly in children who are receiving injectable medications, and we would suggest every 1 to 2 months, depending on what you have available and your resources, and also certainly if there's any clinical concerns, to do them more frequently. Ototoxicity, or hearing loss, is really the most important or serious adverse effect, and the one that parents, children, and clinicians are most concerned about. There's actually a variable risk reported in the literature. It's quite a little bit of a confusing literature. And in adults, the risk is often reported to be 10 to 15% in adults treated with injectable agents for TB for prolonged periods. But some cohorts it may be as high as 50%. And it's the reporting, or the risk, is largely associated with how it's been assessed in the cohorts. And we'll hear a little bit more about the specifics of hearing loss or ototoxicity with these injectable agents, but much of it is above the speech threshold. And so you cannot just ask patients about whether they experience hearing loss. And so how it was assessed in these cohorts is important. In children, as many as 20 to 25% treated long-term with these injectable drugs will have some amount of hearing loss. So how should this be assessed in children, and how should this be followed? This is such an important and frequent adverse effect. And I'm going to hand over to Kayleen to discuss from an audiologist perspective.
Thank you, Tony. For those that's unfamiliar with audiology and audiologists, an audiologist is a health professional who assesses, diagnoses, and manages auditory and eighth nerve and vestibular problems. The importance in the MDR population, as you can see, is early identification of ototoxicity and early intervention. Now, the aminoglycosides is ototoxic to the auditory and vestibular systems, therefore causing a permanent and irreversible damage. It's sensory neural in nature and ultimately affects the speech and language of a child who's developing. Therefore, it has implications on educational, career, and social implications for this young adult or this young infant growing up, and ultimately affects the quality of life. For those that's unfamiliar to the anatomy of the ear consists of 3 parts: the outer ear, the middle ear, and the inner ear. The outer ear consists of the pinna, the ear canal, and the eardrum. The middle ear consists of the eardrum, the ossicular chain, and the eustachian tube. The inner ear consists of the 3 semicircular canals and the cochlea, which looks like a spiral seashell. A normal cochlea versus a damaged cochlea. In a normal cochlea, you have the inner ear cells and the outer ear cells. When speech or the sound is translayed through normal, healthy ear cells, all the sounds are heard. In picture B, below, as you can see, the ear cells are not in equal, nicely arranged cells. So when someone speaks, the sounds are distorted, and therefore the messages relayed is not heard clearly. How to read an audiogram. Usually, when a hearing test is done, it's described on an audiogram. The picture in the left-hand corner is an audiogram of familiar sounds. An audiologist reads an audiogram from left to right, low pitch to high pitch, and from the top to the bottom, from soft sounds to loud sounds. In the diagram on the left hand side, you can see there's a gray looking like a banana. It's called a speech banana, and various pictures displayed on the audiogram to indicate the various hearing levels in decibels of the various sounds that are heard. Usually the speech banana depicts the sounds that are spoken in speech or communication, which we do on a daily basis. If you look at the audiogram on the right, you will see in decibels it says normal hearing, mild hearing loss, and progresses down. If an individual has normal hearing, everything above 20 or better than 20 decibels is heard. As you can see, if someone has a severe hearing loss, which often occurs with the patients on ototoxic medication, at 80 decibels is the softest sound that they'll be able to hear. So anything higher than 80 dB, that's what they'll be able to hear. Essentially, you would like to see a normal hearing audiogram as the one depicted on the upper left-hand corner, where the red circles are above the speech banana. If you are seeing an audiogram that's depicted in the upper right-hand corner, which is called a high-frequency sensory neural hearing loss, that is essentially a typical audiogram for ototoxicity. On the lower left-hand corner, it's a progressive hearing loss due to ototoxicity. You do not want that to happen. If you do see upper right-hand corner or lower left-hand corner occurring, it is an emergency and a red flag in terms of ototoxicity. Sometimes the patients might have a conductive hearing loss, which is the lower right-hand corner audiogram, which is depicted or usually caused due to otitis media, or would be an ENT, ear, nose and throat specialist condition. What you need to look out for when you're treating the pediatric population are risk factors. Risk factors which entail the gender of the child, the age, the dosage, the frequency, as you already heard, any previous noise exposure, whether it's in ICU or just general noisy sounds in the house or the creche, multiple use of drugs, the genetics, if it's available to you, co-infection of the child. Other symptoms which may include ototoxicity, usually it is adults are able to explain to you what's happening and kiddies are not so easy to explain their symptoms. Oral fullness is called blocked ears or tinnitus, which is roaring or ringing in the ears, and dizziness. Usually a pediatric who's a toddler is able to explain to you that their ears are blocked or feels full, that something is singing in the ears, the tinnitus or the tinnitus, or the ringing in the ears, or that they feel off balance or dizzy. Sometimes they're able to explain that they don't hear anything, subjectively hearing loss, and sometimes it's complete deafness. Please look out for the signs of any indications, both subjectively or objectively, looking at the child and assessing to see whether the child is listening to music, responding to loud sounds, complaining of any ear conditions or off-balance conditions. Our testing protocol in Cape Town, usually in surrounding hospitals nationally, we perform a case history, we perform family history of hearing loss, we ask questions, any previous drug treatment, hearing or balance complaints. Perform otoscopy, which is examining the outer ear and the middle ear for any foreign bodies, wax, ear infection or perforations. We perform tympanometry and reflex testing, which to assess the middle ear function, therefore to confirm that it's not a middle ear component or conductive component, but strictly sensory neural. We conduct pure tone audiometry to assess the hearing levels. These may include air and bone conduction, both at the standard frequency and ultra-high frequencies. Standard frequencies are the frequencies used to test for speech, so 250 Hz to 8,000 Hz, and ultra-high frequencies are 8,000 Hz greater. Otoacoustic emissions are used to assess the cochlear-outer hair cells, and we use distortion product otoacoustic emissions. The brainstem, auditory brainstem response, or BARE, brainstem auditory evoked response, is used to assess auditory eighth nerve function. Some age-appropriate testing recommendations. There are various documents which you may search to find these recommendations. What we currently use in Cape Town and nationally are 0 to 3 years, 4 to 6 years, and 7 years plus. Any children that are able to perform the test subjectively by following instructions usually go into the pure tone audiometry range. For the 0 to 3 years, we perform otoscopy, tympanometry, reflexes, visual reinforcement audiometry, play audiometry, DPOAE, and ABR. Visual reinforcement audiometry is usually based on conditioning or conditioned stimulus. Play audiometry is usually where we would put a play peg box or some toys in front of the pediatric and ask them to respond or place a block on a peg box when they hear the sound, and we would reinforce. For 4 to 6 years, we do the same things, except if the child is able to press a button or raise their hand. So for the age-appropriate testing, as I recommended before, 0 to 3 years, 4 to 6 years, and 7 years plus. If you are unable to procure any equipment besides one single machine or 2 items of equipment, then try to order an otoscope and a DPOAE machine. Getting back to the management where we left you, you may change the injector
Other additional points about the ototoxicity of the injectables. There's often questions about whether the choice of medication may influence the risk of a child or an adult developing ototoxicity. And there does seem to be a thread in the literature and in recommendations that capreomycin may have a lower risk of causing ototoxicity, and that may be true, but there's actually not good objective data to say that that's the case. And I think it's important that clinicians should not consider that capreomycin is safe and won't cause ototoxicity. It does, and we don't really know whether one agent is a higher risk or the other. So they should all be assumed to be a high risk of causing ototoxicity. What about the choice of dosing regimen? So could giving intermittent doses like thrice weekly or twice weekly reduce the risk of developing ototoxicity? And it really doesn't look like that's the case. Most likely the pharmacokinetic correlate of ototoxicity is total drug exposure. So it's not that higher maximum concentrations increase the risk, or spreading out the dose doesn't reduce the risk. It's the total drug exposure over time that the person is exposed to that is most likely the correlate of the risk of developing ototoxicity. So if you give the same total weekly dose 3 times, divided 3 times for thrice weekly dosing, or if you give that same dose divided daily, the risk of ototoxicity is most likely to be the same. And I think it's important for clinicians to understand that if you give the same total dose, spreading it out doesn't actually reduce the risk. Really, if that's the case, that the correlate of ototoxicity is the total drug exposure, then the way to reduce the toxicity is actually to reduce the total dose and the duration that you give that dose. The challenge for these injectable drugs is that they're also concentration dependent, so their activity will be increased with a higher dose and decreased with a lower dose. So you really have to balance those two things. And it's important to realize if you're reducing the dose and the duration, you're also reducing the efficacy of these agents. As was mentioned, ototoxicity really is not uncommon in children. Really, 20 to 25% of children receiving these drugs for prolonged durations will end up with some amount of sensory neural hearing loss that's permanent. And so this is important to monitor for. And it may influence treatment if you're monitoring it. If you catch it early, you can consider stopping the injectable, as Kayleen mentioned, and switching to other medications. The choice to do that depends a lot on what other medications you have access to, on how sick the child is, how severe their disease is, how well they're responding to treatment. So that has to be considered on an individual basis. But if you don't stop in the injectable, the hearing loss can progress, can become more severe, and can progress to total deafness. So it is important to monitor for ototoxicity in children receiving these medications for prolonged periods of time. But it's also important to note that the inability to monitor for ototoxicity should not limit the use of an injectable when it's otherwise indicated. So MDR TB is an important and serious condition. It's treatable. If not treated, it can have high morbidity and mortality. So if you're in a setting where you can't monitor for ototoxicity and you have a child who has MDR TB, you should treat them with the injectable medications. And you should also advocate for appropriate monitoring tools and access to those tools in your setting. A couple quick points about the future. So there are some interesting studies and really in animals about medications that might prevent ototoxicity. And these are really antioxidant medications. There's a large literature in animals. Aspirin and acetylcysteine NAC are potentially clinically relevant medications that could be given along with the injectables that might prevent ototoxicity. There is some evidence, a small clinical trial of aspirin in adults receiving short courses of gentamicin that it did decrease ototoxicity, but it hasn't been studied in MDR TB, and this might be an important consideration. Really, the way to reduce the serious adverse effects and the poor tolerability of these agents is actually to get rid of them from the regimens. And that's not possible for most adults and children at this point, but there are trials ongoing and planned of injectable sparing treatment regimens in adults, and beginning to be discussions about looking at that in children as well. So pulling some of these learning outcomes and issues that we've discussed up till now, a 2-year-old male presents with 1 month of cough, fever, weight loss, and a chest radiograph with hyaluradenopathy and right upper lobe opacification. A gastric aspirate is positive for MTB resistant to INH and RIF, and a diagnosis of confirmed pulmonary MDR TB is made. The child is started on MDR TB treatment. The question is, what dose of kanamycin should be prescribed for once daily IM dosing in this 10 kg child? Kanamycin or an injectable would be indicated because of the confirmed MDR TB. So 300 milligrams, 175, 100, 500, and 750.
So while we were waiting for you to get back to the line, I already took a this question, so you can just go over the answer to this and then move on to the second case.
Okay. Great. So as we said, really we feel like the most appropriate target dosing range is 15 to 20 milligrams per kg, and that would the dose for this child would be 175 milligrams would be appropriate. The other doses would be too high or too low, most likely. Again, the evidence for this is fairly low quality, but I think it is appropriate, certainly reasonable practice at this point based on what we know. So how would you advise the TB nurse to administer this IM injection that you've just prescribed? You can see the options there for site and size of needle. And then lastly, so monitoring for ototoxicity. Which one of the following components of audiologic monitoring is not likely to be feasible and age appropriate in this child? Or this is a young child. Okay, that's excellent. So yes, pure tone audiometry would primarily be for older children and adults and rarely be able to be used in children less than 4 years of age. And along with measures of middle ear function that Kayleen discussed, OAEs may be the best option in this young child for monitoring ototoxicity. Okay. So I think we'll wrap this up and we can see if there's any interest or time for questions. But to conclude, the injectable medications remain an important component of current MDR TB regimens. Knowledge about the efficacy, dosing, administration, and how to appropriately monitor them in children is critical. Age really is an important consideration when deciding on safe administration method, and Anne gave really a nice overview of those considerations. And also when monitoring for ototoxicity, you have to consider the child's age and what's feasible and appropriate to use. Really, injectable sparing regimens are an urgent priority, and given the risk of serious adverse events, finding regimens that effectively treat TB in adults and children that do not use injectables is really an urgent priority. But until then, all of us who are treating children with MDR TB really need to use these medications in the most optimal and the safest way possible. So I think that concludes the presentation. Apologies for the technical difficulties. Our contact information is here if there's questions after the presentation. And Evgenia, maybe you can guide us about whether to answer any questions.
Yes, thank you so much for this presentation. There are 2 questions outstanding now. If you can take those quickly as we're already running out of time, that would be great. And as I mentioned before, this webinar was recorded. We will also post slides on the website to provide information at the end on which and how to find them. Thank you.
Okay, great. So the first question is, are there additional issues with injectables in HIV-positive children? I'm going to let Kayleen answer.
So in the data or the research based on adults, if the adult is HIV positive, they actually have a higher risk of acquiring ototoxic hearing loss than if they were HIV negative. In the pediatric population, with the population that we serve or that we see in our country, is usually high HIV related and combined MDR TB. Our HIV population, we're usually looking at conductive hearing losses, so otitis media, anything that affects the middle ear. So if the child already is HIV positive and receiving additional drugs for the MDR that primarily affects the cochlear hair cells, we have 2 sections of the ear, the middle ear and the inner ear that's being affected. In the adults, we've seen that the HIV positive is at higher risk. The studies with the children, there aren't many studies, but I suppose if there is HIV positive plus an injectable for ototoxic monitoring, usually what we find, the child usually has the conductive component which we need to sort out before it gets into the inner ear where the cochlea is then affected. But you can see on the hearing test, on the audiogram results, that there's both a conductive and a sensory neural component, and then we classify it as a mixed component. So there's deterioration or damage in both sections.
Thanks, Kayleen. The second question, are there currently any ongoing trials to study the efficacy of injectable sparing MDR TB regimens in children? I mean, that's a very good question. There's a lot of thought about how best to evaluate and study TB regimens in children. And in general, it's not necessary to study the efficacy of regimens in children if the efficacy has already been shown in adults. And in a lot of ways, it's much easier to evaluate efficacy of TB medications in adults than in children. So there are a number of ongoing trials in adults looking at regimens that don't include injectables and other regimens that may include injectables but for shorter durations and shorter total durations of treatment. If those regimens are shown to be efficacious in adults, then children theoretically should be able to access those, or they should also be efficacious in children. The key considerations for allowing children to access regimens that have been shown to be efficacious in adults would be whether the medications, whether there's appropriate dosing and pharmacokinetic and safety data in children. So as long as the medications are dosed in children that result in the same exposure as in the adults who received those efficacious injectable sparing regimens, then the effect should be the same in children. So really a key for allowing children to access injectable sparing regimens that are being studied in adults is to understand the PK and safety of these medications in children, and also to make sure that there's child-friendly formulations of the medications. So if there's only adult formulations that can't be administered to young children, then they may not be able to receive those same injectable sparing regimens. It may be that there's children who have minimal disease or non-severe disease who already in some settings are receiving injectable sparing regimens, shorter or regimens where the injectable is given for shorter amounts of time. And there's some ongoing discussion about whether studies specifically in children are warranted and how best to do that. It is an important priority, especially given the long-term effects of hearing loss and the pain that these agents are actually causing children. It is a priority for those interested in advocating for children with TB to find injectable sparing efficacious regimens for children.